Thank you very much, Virgin, for the kind introduction. What I hope to do today is to give you an overview of how we diagnose and treat light chain amyloidosis. So Yokchin alluded to the fact that amyloidosis is a heterogeneous disease, many different subtypes. As hematologists, the subtype that we focus on is immunoglobulin light chain amyloidosis, also known as AL amyloidosis, because this arises from monoclonal light chain that's produced by clonal bone marrow plasma cells and sometimes B cells. So these clonal plasma cells produce an excess of clonal free light chains. And in some situations, these misfold, which exposes hidden epitopes, predisposing to the formation of prefibrillar aggregates. And these in turn form beta-pleated amyloid sheets, which deposit in organs and cause organ damage. The prefibrillar aggregates themselves can sometimes cause direct tissue toxicity, especially to the heart. And as Yokchin mentioned, the amyloid fibrils can deposit in between the cardiomyocytes, disrupting the architecture of the cardiac tissue. And interestingly, the free light chains themselves, even before they become amyloid, are toxic to the cardiomyocytes and can induce apoptosis. It's also been shown that certain mutations in the variable gene of the free light chain can directly can target the amyloid to specific organs, for example, the heart and the kidney, as illustrated here. So it's apt that we're discussing this in a cardiac amyloidosis masterclass because cardiac involvement is one of the most common organ involvements in AL amyloidosis. And these patients often present with symptoms of heart failure. Renal involvement is also relatively common with the nephrotic syndrome being one of the most common presentations. Soft tissue involvement can also happen at a variety of different sites. Neurological involvement may be more common than is recognized, and it can affect the peripheral and autonomic nervous system. And lastly, gastrointestinal involvement is very important. The diagnosis of amyloidosis requires histopathology. And you might recall the Congo red under polarized light showing this apple green birefringence. And one of the factors that we can struggle with as clinicians is deciding which organ to biopsy. So fat pad, salivary gland, bone marrow, rectum, these have all been described as potential sites. Biopsy of the organ that's involved often provides the best yield, but can also be associated with the highest risk. So some clinical judgment and the utilization of expertise, such as what Wei-Chin and his team has proved very important here. So once we have established the diagnosis of amyloid, the next step is to subtype the fibril accurately, because it makes a big difference what subtype of amyloid the patient has. So immunohistochemistry can achieve this in about 60% of patients. However, mass spectrometry is the gold standard. And this has a very high sensitivity and specificity for distinguishing between different subtypes of amyloid. Now, once we know we're dealing with a light chain amyloid, the next step is to evaluate what type of plasma cell or B cell dyscrasia is driving this. And I will talk about this in a bit more detail next. And lastly, we want to assess what degree of organ involvement we're dealing with and the staging. So when we're evaluating a plasma cell dyscrasia, the first step is to characterize and quantify the paraprotein. Right? So there are a number of standard techniques that are involved here: serum electrophoresis, immunofixation, serum free light chain assay, and M-band quantification. We also want to look for clinical features of multiple myeloma, which we use CRAB as the acronym. And these basic investigations help to establish that. On the bone marrow aspiration, we're looking for these cells, which are plasma cells. And we would also do karyotyping and FISH, looking for chromosomal abnormalities specific for myeloma. So the key question we're asking here is this light chain amyloid happening in conjunction with myeloma, or is this driven by MGUS, right, which is a precursor state to myeloma? So once we've established that the patient has a light chain amyloid and we've characterized the underlying B cell or plasma cell clone, the next step is staging. And there are a number of different staging systems have been proposed, but the one that we use and the one that's probably most widely used worldwide is the revised Mayo staging system. And this comprises of three components: troponin, BNP, and the differential of involved over uninvolved free light chain. And we derived that from this test called the serum free light chain assay. So if a patient has none of these points, they're stage 1. If they have 1 point, they're stage 2. If they have 2 points, they're stage 3, and so on. So the Mayo staging system provides us a nice distinction between the different stages, of course, with stage 4 patients having the worst outcome. And another point to highlight is that there are two key determinants of survival: the plasma cell burden, as determined by the free light chain assay, and cardiac involvement, as shown by the BNP and troponin. More recently, it's also been identified that having a specific translocation called 1114, which leads to upregulation of cyclin D1, also has an adverse prognostic effect, specifically in patients who are younger, have fewer involved organs, and are early Mayo stage. Right? I will come to the therapeutic significance of this later. So one thing that's sometimes overlooked is how important supportive care is in the treatment of this disease. And the meeting we're having today is a multidisciplinary meeting, and that's a reflection of how light chain amyloid should be treated. So we need input from all these different specialists. And we can't forget nursing and intensive care support, monitoring of fluid balance, orthostatic hypotension, prompt treatment of infection, and treatment-related complications are all critical aspects that should not be overlooked. But when we're talking about definitive treatment for light chain amyloidosis, the current paradigm is that we are targeting the clonal plasma cells. So by removing these clonal plasma cells, the idea is we remove the source of the light chains and therefore reduce the chance of further fibril formation. And what we aim to achieve by doing that is, number one, a hematologic response. And what that means is we want to see a reduction as far as possible of these light chains. So we want to see a negative immunofixation and a normalized free light chain ratio. And what we hope to see following on soon is an organ response. Right? And the organ response differs based on the organ we're dealing with. So for example, for renal, we're looking at a reduction in proteinuria. For the heart, we're looking at a reduction in the BNP. And we can also combine the hematologic and organ response together in this CHOR model. So since we are targeting plasma cells for this disease, a lot of the treatment is extrapolated from multiple myeloma, which is a far more common plasma cell malignancy. A number of different treatments have been described for AL amyloidosis, but in the last decade, this regimen, which we call VCD, bortezomib cyclophosphamide dexamethasone, it's called CyBOD in the US, has become the standard of care. And typically it's used as 4 to 6 cycles of induction treatment with VCD. Responses are assessed as I described earlier. And if the patient has no cardiac involvement, or if we are able to reverse existing cardiac involvement, we would strongly consider taking the patient to an autologous stem cell transplant to consolidate the response that's been achieved. Now, about 3 to 4 months ago, the Andromeda trial was published, which has the potential to be a game changer for light chain amyloidosis. So daratumumab is a monoclonal antibody targeting CD38. So CD38 is expressed on plasma cells, and daratumumab is really good at killing plasma cells by direct toxicity, as well as engaging a variety of different immune effector cells. And in Andromeda, they did a randomized comparison of daratumumab VCD compared to VCD in almost 400 newly diagnosed amyloid patients, which is a great achievement for such a rare disease. And there was a good representation of patients with cardiac disease. The primary endpoint of this trial was hematologic response. Not surprisingly, they achieved that. But what I feel is more important for patients is this difference in organ response. And we are seeing unprecedented degrees of cardiac and renal responses in the daratumumab group. And this was at a very short follow-up of about 1 year so far. So this study has established daratumumab VCD as the new standard of care for light chain amyloidosis. However, there is an important unmet need in light chain amyloidosis. So we are very good at killing plasma cells based on the success in myeloma. But what about the amyloid fibrils that are already in the organs? And this is one of the causes of morbidity and mortality for these patients, which we have still not been able to address. So there are some up and coming therapeutics which might help with this. Venetoclax, it's not a fibril directed therapy, but it is highly effective against myeloma in myeloma cells with 1114. And as I mentioned earlier, this is a prominent feature in light chain amyloidosis. So this is a space to watch. Probably, maybe more importantly, are these drugs, the fibril-directed antibodies. And in early phase studies, we are seeing this one, CAEL-101, resulting in organ responses in excess of 50%, which has not been seen before with purely plasma cell-directed therapy. Unfortunately, this antibody, although it showed good responses in early phase studies, a recently published randomized study showed no benefit. But there may be a signal of efficacy in cardiac stage 4 patients. So how can we take this forward? These are just my opinions. I feel that using CD38 monoclonals together with 1114 targeted therapy plus fibril-directed antibodies early in the disease, before the fibrils get established in the organs, may be the way forward. This would be a chemo-free approach. So we are negating neuropathy from bortezomib, minimizing cytopenias, and hopefully resulting in an effective and well-tolerated treatment for these patients. However, as illustrated by Andromeda, doing such clinical trials in these patients requires international collaboration. And hopefully we can achieve that, because that's probably our best chance to improve the outcomes for these patients. Okay, I think that's my last slide. Thank you very much for your attention.